We'll figure out how to show our screen, and then we'll get started. There we go. I got to tell you, it's a little strange to talk to a computer screen, knowing that there's people somewhere on the other side, but we'll try to figure out how to make sense of this technology. We're totally open to folks asking questions as we go along, so feel free to type. Polly has promised to yell at me if I don't see that you've typed, and Tim and I will watch the screen and try to punch each other if you guys type a question and we aren't seeing it. So we'll try to make sure that you can interact with us.
Okay.
So, want to talk about what we're going to talk about?
Sure. So today we'll be discussing managing multiple relationships within a primary care behavioral health setting. What got us thinking about this is that the challenges with regard to ethics and multiple relationships feels very different in primary care than it does in traditional mental health settings. The challenges are different in terms of because we provide different services, and also because most of our training came from a perspective that was more of a traditional mental health care setting. So there are different options in terms of ethically providing services and different challenges that come up in primary care. So that's what got us interested in this topic. So today what we'll be doing is describing a matrix that we developed to help with decision making in terms of making ethical decisions about navigating multiple relationships in primary care.
Awesome. And we'll walk you through that matrix with 3 different cases to help you understand it. We did want to remind you that today's webinar is being recorded and will be posted on the website in case you want to see the slides or refer back to anything. Okay, so this is a scenario that is pretty typical for primary care. We'll read it to you and set the stage for what we're going to talk about today. So Jennifer, she's going to be referred to as patient 1, is a 45-year-old Latino woman who has seen the psychologist Dr. Vine for 10 sessions. They focused on post-traumatic stress disorder because she doesn't have mental health care anywhere else, or longer-term treatment options to deal with post-traumatic stress disorder. And she also has diabetes, so they focused on diabetes management as well. She has trouble adhering to her physician's diabetes management recommendations, and so the psychologist was called in to help with that. She finished with her therapy around PTSD for now, but wants to bring her son, he's referred to as patient number 2, in to see Dr. Vine. The son has no health insurance, and he sees the family physician because of his debilitating anxiety. So she wanted the psychologist to also help with the anxiety. The physician asked Dr. Vine to come into the appointment for a consultation during the medical appointment today. So
this case has a few points that are commonly occurring in primary care settings. One, you have a patient who does not have access to services elsewhere. Oftentimes people do not have access to services elsewhere or are unwilling to go to a specialty mental health clinic. And we'll talk a little bit more about some of the kind of what research has shown in terms of people accessing specialty mental health. 2, the patients know each other. Within a family medicine setting, this is a very, very common occurrence. And then 3, the combination of treatment focus on both mental health and on medical kind of chronic disease management. Those are all things that make primary care, that are common in primary care and are also kind of unique to the primary care setting. These types of things happen with much less frequency in a more traditional mental health setting. So some of the questions that we were thinking about when we were talking about this case, and we'd like you to be considering, are these. Could the multiple relationships in this patient encounter cause harm to either patient? What types of services could be provided to the son in this scenario? That question is one of the main things that I think distinguishes primary care from traditional mental health. In traditional mental health, the way most of us were trained is essentially with a binary decision-making process. Can I provide services or can I not provide services? Within the primary care setting, there's usually quite a menu of services you can provide. So the question isn't can I provide services or not, it's what types of services can be provided, while in order to maximize benefit and reduce harm as much as possible. And then the issue of bias comes up when you have a patient that you've known well. So we kind of made bias and considerations of bias a theme as we're talking about this. So those are some of the things we'd like you to be thinking about. We're now going to provide a little bit of context about the primary care setting and why this topic is important.
So as you know, primary care physicians see the whole family, and when a behavioral health provider looks at a primary care physician and says, hey, I know this patient and I've already treated them for several sessions, so I can't see their child or their husband, the primary care physician's eyes get really big and they say, what are you talking about? We don't understand that. So that's one of the reasons that we have to figure out how to negotiate this a little bit differently so that we don't shut down our relationships with our primary care practice. And as we move towards doing population-based care, it becomes even more critical that we open up doors. So just to remind you about the definition of multiple relationships, I'm going to focus mainly on the second part of the APA Code of Ethics. We can't go over every single profession's Code of Ethics, unfortunately, so we're going to focus on that for psychologists just for simplicity today. So APA says that at the time, a multiple relationship occurs when, at the same time, two patients who know each other are in a relationship with a person closely associated with or related to the person with whom the psychologist has a professional relationship. Let me say that again because I don't think I said that correctly. A psychologist in a professional role with a person and at the same time is in a relationship with a person closely associated or related to the person with whom the psychologist has a professional relationship. So basically the psychologist has a relationship with one person and then with another person. And that's what we're going to talk about today in terms of ethics. APA also talks about the fact that psychologists are not supposed to enter into multiple relationships because they may have their objectivity impaired, or there may be competence issues or effectiveness and performance issues, etc. But the code also says that multiple relationships are not always problematic, so it doesn't prevent all multiple relationships.
I think a lot of times in our training, there's a bit of a knee-jerk reaction to avoid any kind of multiple relationship. And in a traditional mental health setting, that may be an adaptive way to approach it. But in primary care settings, particularly in family medicine type of settings, that perspective is really going to limit the ways in which we can benefit patients and we can benefit the clinic as a whole.
Okay, so the problem in primary care, as you all know, is that one physician who works 210 days a year will have a patient, number of patients ranging from 700 to 4,200 depending on the frequency of the visits of the patients. So that's a big panel. Typically our practices will draw from one geographic region of the country, or not the country, of the city or the community where the patients live and the physician is practicing. And we're getting more and more behavioral health providers into practices. However, we still aren't very financially viable. So typically a practice will only have one behavioral health provider because of the finances. Again, that all adds to the dilemma.
So many of you have probably seen some of this research, but a majority of primary care visits have a psychosocial component of some sort. That could be comorbid depression, anxiety, or anxiety along with medical issues. There could be a focus on things like adaptation to and coping with chronic illness. There are many times where psychosocial components are important in the primary care visit. And again, 40 to 63%. So in some studies, a majority of people who have psychological problems, mental health issues, are getting their treatment in primary care, not in specialty mental health clinics. So a lot of care is happening there. And when patients are referred out, only 10% comply. That number jumped out at me. When we make those referrals to specialty mental health, oftentimes there are many, many barriers coming up for people to actually follow through with that referral, both logistical and sort of perspectives with regard to stigma and mental health. So being able to provide services in-house is really a crucial thing to be able to do.
So if we have a flexible integrated primary care program, there are many benefits. So if we have very rigid constraints, then a lot of patients won't get any services. We've already talked about the fact that some interventions aren't available in traditional mental health centers that are outpatient focused. For example, health behavior change is not something that most folks are trained in, working with diabetes or working with hypertension, and typically that becomes more of a specialty in the primary care setting. And then accountable care, which includes the provision of better care for lower cost and population-based strategies. We're all implementing those, such as things like group visits and other ways of connecting with our entire population. So with that being something that we are expected to do, particularly with patients that are medical home, then we need to figure out how to be more flexible.
So again, within primary care, what we're emphasizing today is not, the question is not, can I see this person or not? The question is, what services can I ethically provide? How do I maximize the benefits to this patient and reduce the likelihood of harm as much as possible? That's a much different question than it would be in traditional mental health. And again, because the range of services that we are able to provide are in primary care are much more broad. So consultation, psychoeducation, motivational interviewing, health behavior change, which if someone were to show up and ask for treatment kind of focusing on a health behavior change type of issue in a traditional mental health setting, they probably wouldn't be able to get services due to waiting lists, due to people not seeing that as something that traditional mental health deals with much. So there's something that we can really provide fill a gap. We can also do things that don't involve actually seeing the person. We can refer, we can consult with the physician to help them with making treatment decisions and to help them process their own reactions to some of the frequently showing up patients who have chronic pain issues and are frequently in distress. So there are many different layers of support we can provide both to the patient and to the provider.
Okay, so this is a picture or a slide of the matrix that we developed to try to sort through the questions and the dilemmas that arise in primary care. Please make sure this is a point where you stop and ask some questions if you get confused, because we're going to refer back to this over and over and over for the rest of the presentation. So if you look across the top, we have 3 different categories of risk: low, medium, and high. And across the left-hand side of the chart, we have 3 different dimensions on which we're going to rate our risk. So treatment duration, how long we've known the patient. So this is relational. What's the relationship like for the patient, between the patient and the behavioral health provider? The chance of future contact. So is this going to be low chance of contact or high chance? And then the type of service provided. So popping back to the top line, under low risk of harm, we've categorized brief treatment. So this is a single contact or a few contacts. If you move to the middle, that's more of an intermediate duration of treatment, so maybe 4 to 10 contacts. And then higher risk of harm is going to be the longer relational therapy, where maybe the therapy gets a little bit deeper. Maybe as a behaviorist and talking to the SIG, maybe I shouldn't say psychodynamic, but I'm just going to put it out there because you'll all know what I mean. So longer duration of treatment. And so we arbitrarily assigned these values, the contact numbers, to our chart. It's flexible. So if our numbers of 1 to 3 for low risk, 4 to 10 for medium, and more than 10 for high don't fit for your practice, then that's something that you can consider changing. I think we have a question. Oh, Polly wants us to remind you that you will have access to the PowerPoint and the recording after the webinar. Okay. Right in the middle?
Sure. So chance of future contact. This can be a difficult thing to predict in a lot of settings. When you're looking at family medicine clinics and you have people seeking their medical treatment there over a long period of time, then sometimes it's hard to predict if they'll have future contact with you as a behavioral health provider. But that's something to be considering. Are you actively involved in this person's treatment in any way? Are you helping with health behavior change groups that they're involved in? Are they someone who tends to be a bit of a frequent flyer in the clinic, where the likelihood of you being called in to work with that person is increased? So thinking about the likelihood of you seeing the person in the future, that's an important factor in deciding the risk for harm.
And then finally, the type of service provided. Again, this is where I think it gets really fun, because we can think a little bit differently about the range of things that we're providing. if you jump over to the bottom right corner, I'm going to go out of order this time, and you think about more of a high risk of harm, we're talking about longer-term therapeutic services that are relationship-oriented with high level of patient disclosure and vulnerability. This is something, if you have along the integrated care spectrum, we may not have as much of that in my practice here at Swedish Family Medicine, where we're doing a lot of point of care and very limited numbers of sessions because we want to serve the whole population. But in different communities that have different setups than we do, maybe they still have more of a co-located practice because there's not places to refer patients to for longer-term care. They may be much more likely to have these high risk of harm scenarios with patients and have more patients that fall into this bottom right corner. So now I'm going to move back to the other side of the matrix and talk about low risk of harm services. And we decided those could be consultation with or without the patient present. So if something was really tricky and, for example, maybe I had seen patient number 1 that we referred to earlier. Maybe I seen her in a co-located practice for maybe 30 sessions, and we had done all kinds of deep work around her trauma history, and then she wanted to bring her son in. Maybe the most appropriate type of service to provide her son would be consultation with a physician outside of the room, not in the patient's presence, if for some reason we decided it would be very unethical to meet with the two of them together. So consultation could always occur in our practice with a physician, teaching the physician how to navigate that issue. And then in the medium category would be brief interventions. So it may be appropriate to walk in, if you know 2 patients, and do some education about the problem, or teach a specific skill that might only take 1 session. Or maybe you teach it in the context with the patient and the physician, have the physician follow up with the patient next time. Or maybe do some motivational interviewing around some health behavior change. But there's plenty of opportunities to offer all kinds of services to patients depending on how you want to categorize the risk for harm. Any questions right now about this matrix before we move on? All right, we're going to move on. Oops. Did we have a question pop up? No. Okay, we're good.
All right, so we're going to run through 4 steps that we've developed for using this matrix to navigate these multiple relationships. So 1, assess the current relationship. So assess the relationship that you have with the patient that you already know, have already been seeing, kind of the first person you had contact with. So we're going to go through some cases where we'll do this. We'll assess the current relationship with the 3 dimensions we just discussed. Now, really what you're doing here is you're stepping back and you're assessing the relationship as it exists now, as it already exists. So these factors have already kind of been developed in terms of how well you know the person, how deep the therapy has gotten. You probably have a fairly good sense of a chance of future contact, and you know how long you've been seeing the person. Once we think about the relationship and kind of frame it with this matrix, then we're going to look at the relationship for the second patient, for the other person who has a relationship with the first patient. And here we may be able to use the matrix to be a little bit more creative and find a treatment framework that allows us to maximize benefit and minimize harm. So maybe the number of sessions is reduced because we know the first patient more. We have a little more flexibility in developing a treatment plan here. Question 3, or step 3, examine the potential harm if the second patient is not seen. Oftentimes when we go through ethics trainings in graduate school and in continuing education, there's a big emphasis on the potential for harm if we do see the patient. There's a big emphasis on that most of the time. Within primary care, again, because of logistical, cultural, perspective type barriers to accessing traditional mental health, they may not be able to be seen outside of your clinic. And if that's the case, what's the potential harm of that happening? We think that this is an important thing to kind of provide some balance to understanding the risk-benefit equation. And there's always the option for consultation. The integrated primary care community is very collaborative, and I think people enjoy fleshing out these types of problems. So it's always helpful to talk to a colleague.
Okay, so we're going to go through each step with our initial case that we presented to you. So, assessing the current relationship along the 3 dimensions for patient 1. If our relationship ends up being in a high-risk category on multiple factors, then we're going to consider the potential for harm to be higher and our level of caution to be higher. So, here's the case again with Jennifer. Jennifer's in green up here. I'm pointing at the screen, but you guys can't see me pointing. We also can't giggle together, which is a little bit awkward. Okay, so Jennifer is our 45-year-old Latina woman who's seen Dr. Vine for 10 sessions and focused on PTSD. So we are going to look at our matrix, which and the duration, according to our number of 10 or more contacts, would fall into the high risk of harm category. So you can see that we put a 1 to represent Jennifer in the top right category of the worksheet here on the left of your screen.
So Jennifer is patient number 1. That box on the bottom left of your screen has a number 1 to represent patient number 1. And the duration of treatment for her, we put that as high because within primary care, to see someone for 10 sessions is on the long end of what we typically have seen in the clinics we work in. That may vary depending on the clinic you're in. So with chance of future contact, she's finished her treatment for now, so the likelihood of seeing her soon for continued treatment is not necessarily real high, but she's someone who comes to this clinic, so at very least there's a medium likelihood of future contact, and that may be even kind of medium moving toward the high end.
She might even need a tune-up, so she may, kind of circle back around to touch base with Dr. Vine again when she has some kind of trigger from her trauma, for example. And then level of service involvement, since this was more relationship-oriented, over 10 sessions as they talked about trauma, and the patient had to be extremely vulnerable as they discussed the trauma, we rated that as high on the level of service involvement.
So as you look at this patient as a whole, the nature of the relationship, the level of disclosure, the type of treatment, they all kind of lean toward, and the duration of treatment, they all kind of lean toward a fairly high-risk situation. One thing I'd add too is, sometimes we think of, trauma-related treatment as not something that would happen much in primary care, that we'd want to refer that to specialty care. But again, sometimes it's hard to refer people to specialty care and get them to actually go. And 2, when you think about the research about survivors of trauma and survivors of adverse childhood events and the frequency with which they report medical, physical type issues, that the likelihood of them showing up in primary care and complaining of more of a medical issue is actually quite high. So this scenario coming up in primary care is certainly within the realm of pretty frequent occurrence for us.
So now we're going to move on to step 2 on the matrix, which is to look at the potential relationship. So Jennifer's son, and he is patient number 2. So if this relationship is also in a high category on multiple dimensions, then treatment with him should not be initiated at all. But if it's in the mid-range or towards the left side of the dimension, then it may be permissible, and we'll talk about that. So again, the son is patient number 2, and on the bottom left side of your slide, you'll see the blank chart, and we filled in where we think he might fall with indications by the number 2. So we've never seen him before, so we have basically no duration of treatment with her son, and so we rated him as low risk of harm. We've had absolutely no contact, but right now we're thinking we might have 1 or 2 contacts. So when we talk about patient number 2, we're kind of looking into a crystal ball to think, based on the limited amount of information we have, what might happen. So it's a little forward thinking. So low risk of harm for duration, chance of future contact. If he has debilitating anxiety, and that's all we know from our referral, he might need to be seen 2 or 3 sessions, maybe even a little bit more. So we were a bit generous in the number of sessions we gave him in our little fantasy world here of our matrix, and decided to put him in the medium category.
Sure. And so for level of service involvement, because we have worked extensively with his mom and we know her well, because of the nature of that treatment, we're probably going to need to keep our level of direct service involvement on the low side, so we can consult. We might be able to provide some very brief psychoeducation, but we're not going to be able to really enter into a therapeutic relationship in the traditional sense with her son.
And of course, you know, part of, in all full disclosure, this is a scenario that was a case of mine with a lot of adaptations to the information, and in the back of my mind, I'm thinking, wow, this involvement was very deep, and there's a lot of family dynamics going on, and a lot of bias that I would have if I were to engage in treatment with her son, and then factoring in, if you'll remember the beginning of the talk, we talked about needing to think about bias. So factoring in all the bias that I would bring into treating the son was another reason to definitely make sure that we kept our service involvement at a low level to prevent any unmet harm on the son based on that bias. Okay, any questions from you guys? I'll count to 10 in my head and then we'll move on. Okay, that was a fast 10. We're going to move on.
All right.
Now we're on step 3 of our matrix.
Yes. So we've done step 1, which was assessing the current patient. We've done step 2, which was assessing her son in terms of the matrix. Now we're going to do step 3. The potential harm if patient number 2 is not seen. So if you remember, patient number 2 has developed debilitating anxiety and also has no health insurance. So in terms of alternate resources for behavioral health services, it sounds like those would most likely be somewhat limited. The likelihood that the patient will follow through with an outside referral. One thing that wasn't talked about in this scenario is the fact that the mom was in this session with him, and something we don't know is whether the mom forced him to come, whether his level of motivation for treatment is there or not. So that's something that would need to be considered, but the likelihood that he'll follow through with an outside referral based on the health insurance information solely is kind of low. Yeah, so what kind of services could we provide without causing harm? And we kind of talked about consultation or some kind of limited psychoeducationally based services. There's a question about age and social context of the son, and maybe you could speak to that.
Yeah, exactly. So he was a Latino teenager, and very poor neighborhood, mom, didn't even have disability, so really very, very limited financial resources, limited education on the part of the mom, no dad in the picture, so very limited resources for the son.
Could you say something, Lori, about the son's level of motivation for treatment? Was it his idea to come in?
Oh, no. Yeah, right, no. And his level of motivation for treatment was extremely low, very embarrassed to come into the office and talk about this, really being pushed by his mom because of her worry about him and she wanted him to, you know, maximize his potential in school or getting a job, etc. So she wanted something to help him not be as miserable as she was. So thanks for that question. Okay, so I think you guys get the part about harm if the patient is not seen. We have another question? Okay, all right. So moving on to number 4. If we still have questions about whether or not it's ethical, we all know that we're supposed to seek consultation. So that would be our number 4 step. Okay, so we've completed our first case using the matrix. So we're going to go through 2 other cases that are also very common but very different from this case, but very common to primary care.
Okay.
So case 2.
So case number 2. I'm going to read through this and then I'll kind of boil it down because there's a lot of words here. Dr. Delaney is a physician, and Dr. Delaney asked Dr. Vine, the behavioral health provider, to consult with her and a patient named Janet Reed, who is struggling with depression. The consult is completed, and the 3 agree to meet again in 1 month for a follow-up during a regular office visit with the physician. The next week, Dr. Demo, another physician in the practice, asked Dr. Vine to meet with him and a patient named Celine Martinez, a patient who frequently presents to the practice in an emotionally agitated state. So Dr. Vine, the BHP, and Dr. Demo walk into the room. Celine Martinez is sitting there with Janet Reed, the first patient, in the exam room together, and it turns out that they are roommates. So in this scenario, you have the BHP, Dr. Vine, you've got two different physicians, you've got two different patients, and it turns out that the patients are roommates. The first patient you've seen once, the second patient you are now meeting for the first time, and this is a frequent flyer in the clinic, someone who is frequently showing up, frequently has exhibiting a lot of distress, and it's probably a fairly safe likelihood that this person is causing some level of frustration or consternation for the providers. So again, the questions we're thinking about with this: could the multiple relationships in this encounter cause harm to either patient? What types of interventions can ethically be provided to each patient? And what are the potential contributors to bias? And can they be ethically navigated? So what we're going to do again is, this is kind of a practice time here. We're going to use the matrix again in order to navigate this situation.
Okay. And we see the addition to the question before. So we'll pop back to answer your question in a minute. Sorry about the timing of that. It's probably a little bit delayed because it's coming across the web. Okay, so we're going to stick with case 2 right now. So we're going to assess the risk of harm to either patient on our matrix. So because we have not worked with either patient very, very long, our first patient, Janet Reed, was a one-time consult, and now we're walking into the room with patient 2, Celine Martinez, and meeting her for the first time. So our duration is very low as far as treatment duration. So we put both patients in the upper left-hand quadrant to rate them on duration. Number 2, either patient could be referred to another provider. Number 2, we're going to assess chance of future contact is our second level of assessment.
So with the chance of future contact, we had patient number 2 as being high because this is someone who, again, shows up at the clinic frequently and is emotionally agitated. It sounds like there may be some chronic issues that lead to this person showing up at the clinic frequently. For patient number 1, when we wrote the matrix, we put a number 1 for medium, but we know that we're going to be meeting with the person at least once more. So really, that's probably medium to high. So the likelihood of seeing both patients is probably in the medium to high range. And the second part, level of service involvement. Because we're just starting with these patients, we have some flexibility here, and we can kind of get creative here in terms of the level of involvement we think we can ethically provide. So we kind of put that in the medium category. We could probably do some brief intervention, some motivational interviewing, some skills-based psychoeducational kind of interventions without too much of a risk of harm there.
So we know that at this point our relationships are early on. If either of the patients has financial resources or insurance, we could refer one of them or both of them out. One of our questions is, could we have potential harm for not intervening with one of these patients? And does that potential harm outweigh the risk of the multiple relationships for harming one or both patients? And that's actually one of the questions that's come up by one of our folks in the audience for our last case. And so we'll talk about that now. So, I mean, some of the things that we think about are if the patient's depression gets worse, for patient number 1, we would definitely want to have a higher level of activity or involvement with that patient. It may be that we refer that patient out if we have a resource to do that. It may be that we work closely with the doctor if maybe as relationships progress, things have gotten more sticky. But we may prioritize that if the depression is getting worse over time. It also may be that we have other staff, like a care manager, that could do some of that navigation for us, allowing us not to have that multiple relationship depending on their level of training. But there are all kinds of scenarios that we could engage in to try to make sure that both patients are taken care of in a solid way.
One thing that comes to mind for me with this as well is the idea of in primary care providing bridging services. So as you get to know a patient and you really know that they need to be in specialty mental health care, oftentimes the likelihood of them going is low, but if you're working with them over the course of a few sessions and you can educate them about what to expect in specialty mental health, kind of talk to them about the potential benefits for that, help them navigate getting that set up and any logistical barriers that are there, and then kind of provide a little bit of bridging and overlap as they get started. That can also be a way to avoid that sticky ethical situation if the person's acuity does increase, while also making sure that they don't drop off the radar and not have any services at all. It reminds me of the case that I actually had when I was here as a postdoc with Lori, where we had someone who definitely needed to be in specialty mental health care, pretty significant bipolar disorder, needed to be involved with a psychiatrist, and there was a 3-month waiting list to get into the specialty mental health in this area. So I ended up providing some bridging services until that person could get in. I think that helped increase the buy-in, and it also gave them a little bit of support during that waiting period until they could get established at the local clinic.
And then one more thing we'll add about this case is, you'll see at the very bottom, the behavioral health provider may help physicians deal with frustration regarding patient 2. This also links back to harm for the patient, because if patients, we all know that if patients have poor physician relationships, doctor-patient relationships, then the doctor is frustrated, the patient might not get his or her needs met. If the communication is poor and the patient is not able to engage with the physician appropriately, there may be more referrals out for tests, which may increase morbidity or harm to the patient. So oftentimes I think we provide a valuable service of helping work with physicians and coach patients in a way that they can navigate that relationship. So it may be that a coaching type of consultation occurs with that patient with no other clinical intervention with patient number 2, so that they work on establishing agendas for the visit, maybe before the physician walks in, and the psychologist or behavioral health provider just works on keeping that patient on task in the session and decreasing that frustration in that doctor-patient dyad. I'm going to take just a second and pop back to answer the question that came up from our first scenario. And just so you guys out there know, the person had asked what the social context of the son was and the mom in our first scenario, and then the follow-up question was, given the patient's limited resources, it appears that may end up in an ethically sticky situation. How would you navigate this situation? So I think our first response would be to refer the son out if possible. If we don't have those resources, then again, keeping both patients, since they came in together, it may be that we can have permission from the mother to meet together with the son and have it in that context. We may provide consultation with the physician and help the physician navigate helping the patient with medication. And then I guess there could be points where our hands would be tied and we might not be able to do anything, but we would do everything we could to open those doors.
It also seems like if you have someone who has debilitating anxiety and is very embarrassed about it and is probably very treatment naive, there's probably quite a bit you can do in terms of just basic education about what anxiety is and what behavioral health treatment is and what to expect with that, and some basic kind of psychoeducational tools in terms of managing anxiety. I mean, in 1 or 2 brief sessions, you could talk a little bit about, you know, identifying kind of increasing anxiety and some basic tools for managing that, things like relaxation breathing. So there are things you can do without requiring a lot of disclosure from the patient. So if you can stay focused on that brief education model, you can probably keep the risk fairly low while also probably providing a pretty big shift in thinking for that patient in terms of their symptoms and their options for managing them. So this is the end of case number 2. You want to move on to case 3?
Yeah.
All right.
Okay, so based on the diabetes registry at Mountain Family Medicine has decided to hold diabetes group visits. They encourage all patients with HbA1c levels above 10 to attend this visit. The BHC's role is to do a standardized mood assessment with each patient and lead a discussion about depression. Janet and Sue attend together. They are roommates and both have diabetes. So this is one of those really fun scenarios that probably is going to occur frequently as you manage a population. So our ethical questions are?
So the first one, MR, stands for multiple relationships. Could the multiple relationships in this patient encounter cause harm to either person? Based on the fact that we just met them both for the first time, we're meeting them at the same time, and they are also in kind of an educationally based group treatment setting. We put them both, we kind of considered the risk for harm here at this point to be fairly low. Second question, what types of services can be ethically provided to the roommates in the group visit? And then is there a risk of bias? The risk for bias in this situation at this point in the encounter is probably fairly low because we're just meeting them both. That may change as it progresses and we find out more about each of their kind of clinical histories. So in terms of duration, we put them both in the low categories because we've just met them, and this is probably going to be kind of an educational group-based intervention. There's no talk of any kind of individual treatment at this point. In terms of chance of future contact, we're going to be seeing them across the course of a few groups probably. Level of service involvement, when we're talking about a group educational setting, we're really looking more at a lower level of service involvement.
We also discussed confidentiality at the beginning of groups and set expectations about protecting each other's privacy as an initial session and probably an ongoing reminder of group norms at each group visit. If during the group it appears that either person might need follow-up for mood issues, we might decide to do another matrix to decide which, if both of them needed follow-up for mood issues, we would definitely do another matrix to figure out, based on the patient's resources and the nature of follow-up needed and the length of time of follow-up that might be needed, which patient might be treated in-house and which patient might be referred out, or both patients referred out. But there are some potential benefits of this scenario. So if both members are coming to the group together, obviously they might get each other there. They might provide grocery shopping trips together. They might have a pact about what goes into the house food-wise and what doesn't. They may provide support for each other and reciprocal reinforcement of staying on track, but also about concepts learned in class. They also may share transportation and other expenses to get to and from groups. So it could be a really good multiple relationship that is beneficial to everyone. Okay. That is the end of our talk.
This talk was based on a paper that we published in Professional Psychology Research and Practice back in 2013. In that paper, we talk a little bit more about bias, and we kind of get a little more in depth with some of the matrix and also some of the background and kind of the research related to primary care and why multiple relationships are highly likely to happen there. So please refer to that if you're interested in this topic. So we hope that this model has been helpful to you and has provided a way to think about these things. We're often in settings where we're doing 4 to 5 things at once, and we're making decisions quickly, and our hope is to provide a little bit of a rubric to be able to make effective ethical decisions quickly in the context of kind of your day-to-day work as behavioral health providers.
If there are any final questions, please type them or tell Polly. I think Polly can hear you.
Sure. Thank you, Lori. And we are definitely open for questions at this point. If you'd like to type some into the question box, or if you're interested in asking verbally, you can raise your hand and I'd be happy to unmute you. So let's just take a moment and answer any last questions. Okay. Just as a reminder, this recording and the slide deck will be available on the CFHA website in probably about a week. So if you'd like to check back, you'll be able to access those documents then. We'd like to thank each of you for joining us today and remind everyone about the upcoming CFHA conference, which will take place October 15th through 17th in Portland, Oregon. Registration for our conference will open in mid-June. I think we're scheduled to open June 15th. We're very excited about the conference this year. And as a final reminder, if you are interested in the PCBH model of integrated care, we'd encourage you to access our website in the PCBH SIG pages, where there's an opportunity to join this special interest group, and monthly they do educational topics and have other opportunities to engage with like-minded folks interested in this model. So thank you all very much for joining us today.